Good afternoon. My name is Ashley Dueñas, and today we're going to be going over occupational therapy and AAC devices. So we're going to start off by going over today's objectives. So by the end of the class, students will identify 3 methods of direct access with 80% accuracy. Given a case study, students will identify 2 switch sites with 80% accuracy. And at the end of the class, students will identify the stages of switch progression with 80% accuracy. So what is AAC? AAC stands for Augmentative and Alternative Communication, which is an area of clinical practice that supplements or compensates for impairments in speech-language production, comprehension, and includes both spoken and written methods of communication. AAC uses a variety of techniques and tools to self-advocate. This can include manual signs, gestures, finger spelling, tangible objects, line drawings, picture communication boards, which we typically see in OT. And today, what we're going to be specifically focusing on is speech-generating devices. And all this information is directly from ASHA. Augmentative is when it is used to supplement existing speech. Alternative can be used in place of speech that is either absent or not functional. And temporary can be used by patients post-operatively, typically in intensive care units. Overall, AAC falls under the umbrella of assistive technology. Typically, when we hear the word AAC, our brains automatically just jump to speech therapy. But today we're going to be specifically talking about OT's role in AAC. So let's talk about OT's role. Our main goal, and I really like this quote from Boston Children's Hospital, is the identification of a reliable, functional, non-fatiguing motor response for direct or indirect access for intentional communication. So here I want to go back and just look at our keywords: reliable, functional, non-fatiguing. So functional in this aspect would be an individual must be able to turn their device on and off and intentionally communicate with it. Our other goals as OT are to determine accessibility, mount a device, and positioning of a client. So let's talk about direct access. So direct access should always be our first goal. This is determined through evaluation of their finger isolation, range of motion, strength, visual motor skills, visual spatial skills, visual perceptual skills, cervical and postural control, as well as their proprioceptive input. Okay, so let's go ahead and talk about some direct access methods. So we have touch, laser, head tracking, and eye gaze. For touch, the individual will use a specific body part. It can be a finger, it can be a toe. They will just use this body part to select a specific target. We then have laser. With the laser pointer would point at a specific target. It can be held in their hand, affixed to their glasses, or to their side of their head. For head tracking, the individual has a reflective dot typically placed on their forehead. It can also be on their glasses, which is read by a camera on an AAC device. The individual then moves their head to select a specific target. And for eye gaze, the individual uses their eyes to select specific targets on the AAC device, and then their eyes are read on a camera on the AAC. These are also some examples of direct access. So here we have a typical keyboard mouse. We then have a trackball mouse and then a joystick mouse. So with the regular mouse, this could be a really great option for an individual that does have that finger isolation and is able to go ahead and click and make their selections. The trackball mouse and the joystick mouse are maybe for individuals that would benefit from that direct access, but maybe don't truly have all of that finger isolation, but they can be able to use their hand to still make their selections. On this screen, we have some more examples of direct access. So here we have an alternative pointer, and it's attached with a universal cuff, and then we have an alternative head pointer. Okay, so we're going to take a minute to watch this video. This is specifically on how eye tracking works with the Tobii Dynavox.
Eye tracking is a technology that is used to see where a person is looking on a computer screen. The technology can also be used to control a computer. Instead of using a traditional keyboard and mouse, you control it by using your eyes. Illuminators in the eye tracker send out near-infrared light that is reflected by your eyes. A camera registers these reflections, and through filtering and advanced calculations, we can determine where on the screen you are looking and then place the computer cursor consistently and accurately. There are certain things that set Tobii Dynavox eye trackers apart from others. Besides an unprecedented patent portfolio and many technical details, one is the fact that we use a unique and very accurate 3D model of a human eye. With this model, you don't need to keep your head still when using a Tobii eye tracker. In fact, you can move your head freely without any significant loss of precision or accuracy. This is particularly beneficial for individuals with uncontrolled head movement, such as those with cerebral palsy. For accurate eye tracking, the eye tracker needs to find your pupils. This can be done through either bright or dark pupil tracking. Bright pupil tracking works similarly to when you get red eyes using a compact camera with a flash. By placing the flash, or in this case the illuminators, farther away from the lens, you can avoid this. This is dark pupil tracking. Tobii Dynavox eye trackers are unique in that they dynamically switch between bright and dark pupil tracking, so you'll always have an optimized eye tracking experience. There are many other things that make Tobii Dynavox eye trackers unique. To learn more, please visit Tobii Dynavox.
Okay, so this is specifically for the brand Tobii Dynavox, but does anybody have any questions? Okay, let's move on. Direct access facilitators may be for that candidate that you believe would benefit from direct access methods, but maybe need a little bit of help. So here's when we can attempt splinting. So here we have an oval 8-finger splint. Depending on where you place it, it can help with a swan neck deformity or a boutonniere deformity. This can assist maybe with that finger isolation. And then we have a wrist splint here. The wrist splint ideally would be able to help maintain the wrist in a neutral position. Here at the bottom, we have a key guard. So a key guard allows the users to rest their hand to isolate better and access the vocabulary they want. This can either be ordered depending on the product used, or it can even be created. A lot of therapists have tried using acrylic sheets, even wiki sticks for like the tactile cues, and even puppy paint can be a really great option. Even though this is considered a direct access facilitator, it can be a little bit more challenging if there are visual deficits. So of course, all of these are really dependent on the individual in particular. So now let's talk about indirect access. So this is going to be our choice when there is not enough motor control. It is the least efficient. This is typically when we use a switch. And the most important aspects to consider will be positioning the client, positioning of the switch, and mounting of the switch. So now let's talk about our types of switches. For scanning switches, there are two types, single switch and dual switch. A single switch would be when one switch starts and that same switch makes the selection. A dual switch would be when one switch starts the scan and the second switch makes the selection. And scanning pattern and speed is going to be dependent on the individual and then depending on the program utilized. So depending on the different programs, they may have different customizations or settings that can help you either change the scanning speed between different rows, different columns, or even between groups. Okay, so we're going to go ahead and watch this little clip. This clip actually does not have audio, so we're just going to go ahead and take a look, and then it'll start over right now so we can take another look. But essentially, the adult or the therapist is activating this big red switch, and that's actually its name, Big Red, to be able to activate this dinosaur. When the dinosaur is activated, it starts roaring, it starts walking, it starts moving, and it lights up. And when the button is not pushed anymore, then you just see everything just stop. With the fan, same thing. When the switch is activated, the fan turns on. When it's not activated, turns off. So here we have different types of switches. So we'll immediately recognize Big Red from that video that we just saw. Switches like Big Red are now available on Amazon, making it a lot more accessible for either clinics, for families to start practicing with. We also see a sip and puff here, which is activated depending on changes in air pressure. And then we see microlight switch, which is activated by very small sensitive movements. So essentially a switch site will use a small, isolated, volitional movement with controlled activation. It will need sustained pressure and controlled release. So this is when we start seeing more of that need for that proprioceptive input. So now let's talk about how do we determine the switch site. So determining the switch site will be dependent on each individual's motor, cognitive, sensory, vision, and hearing skills. It can either be placed on an individual's hand, arm, thumb, head, knees, eyes, feet, mouth, or tongue. So how do we determine the switch site? We first want to begin by observing their movement. This is going to be through evaluation as well as through informal observation. We also want to ask questions to either their parent or caregiver, and if appropriate, to the patient themselves. We then want to select 2 sites to attempt, and then we want to test it out. A lot of this is going to be trial and error, and as we're completing this trial and error, we want to make sure that we position the switch in all planes of movement. These are some examples of the switch site locations. So here we have that they placed the switch above the child's hand. Here, child maybe had a little bit more range of motion or strength, and this was a smaller isolated movement, so it was moved towards the side. Here, maybe we had a little bit more of that control, so it was placed towards the back of the tricep. Here, the thumb is totally isolated. Here, although it looks like it's the thigh, it's actually the knee is where it is placed. And here it is placed below the child's foot. It can also be placed on the left or right-hand side, depending again on each individual's movement. So now let's talk about mounting. So mounting can be external or on person. On person can mean mounting on their wristband, on a wrist splint, or on a hat. It's not used as frequently, so for today we're going to be specifically focusing on external mounting. So mounting can be in collaboration with the OT and the equipment vendor, and we want to make sure that it is always within the boundaries of the wheelchair so that it doesn't get bumped off. We also want to ensure that it is not in view of their communication partner or in the way of propelling. And we want to ensure that the mount can be moved out of the way to allow for transfers. Mounting can also decrease the chances of being lost or being stolen. So here we can specifically see, let me take out my red pointer, the frame clamp that is attached to the frame of the wheelchair. We then have horizontal and vertical tubing and joints, and then we have the mounting plate here where the device would be attached. Positioning. So optimal pelvis and trunk positioning will facilitate the use of the upper extremities. Here we see that optimal seating position. We see that 90-90-90. Although this is the most optimal seating position, most of us likely do not sit like this. And for our different populations, we want to take into consideration tone. Tone is the state of tension in a muscle. So we can have hypotonicity, which is low tone. So this picture here is an example of low tone. We see that neck flex, that back flex, just really that low tone overall. Then we can also see spasticity, which is an increase in tone with movement. So it is velocity dependent. We can also see hypertonicity, which is increased tone at rest, not velocity dependent. And overall, depending on each of our clients, there are supports available to encourage that neutral body positioning so we can achieve that optimal position. So here we have some examples of those body supports. This one is specifically assisting with our cervical and neck control. We have this lateral trunk support, which also has this forearm support to maintain that forearm in a neutral position. And then we have this wedge right here to also help with that pelvic and that hip positioning as well. All right, everybody. So let's take a moment to review what we've gone over. So let's go ahead and get into groups. It can be groups of 3 to 4. And amongst your groups, let's go ahead and talk about these questions. So what is direct access? What is it dependent on? And what are 3 methods of direct access? So let's go ahead and talk amongst your groups. Okay, great job. Okay, everybody, let's go ahead and stay in our groups. We're going to go ahead and talk about this case study regarding switch sites. So this case in particular is actually based off of a kiddo I had a few years ago. She is a 16-year-old female, passionate about music. She is adopted. Her adoptive father is older, and he reports that one of his main concerns is her ability to advocate for herself when he is no longer able to. She receives consultative therapies at school 1 time per month for all disciplines. She currently lives with her father and sibling. Her adoptive older brother has a diagnosis of Down syndrome, and her diagnosis is dystonic cerebral palsy. Her bilateral upper extremity limbs are strapped for safety due to fear of falling off of the armrest and between the wheelchair when being propelled. So let's go ahead and talk a little bit more about this dystonic cerebral palsy. So according to the American Academy of Cerebral Palsy and Developmental Medicine, dystonia in cerebral palsy is a movement that causes increased muscle tone and uncontrollable involuntary contractions, postures, and movements. Children with dystonia have repetitive twisting movements caused by muscle contractions. She also has a diagnosis of dysarthria. Dysarthria is a speech disorder that occurs due to weakness in the muscles necessary for speech production. So, based off of the diagnosis of dysarthria, we're going to go ahead and say that speech therapy recommended a speech generating device or a switch based off of the amount of motor control that maybe she has. We're going to go ahead and assume that it's going to be a switch. So we're here to discuss. I want to hear every answer. Nothing is wrong or right, as long as we can explain maybe that justification as to why, and we can talk about it. So based off of all the information that we've had presented to us so far, what are we thinking? Where can we place the switch? What two switch sites would you guys recommend? Okay, so I am hearing a lot of using her thumb. I think that'd be a great option. Her bilateral extremity is already strapped. Let me see how I can place it right here. Is already strapped, so having that thumb would be a very small, very volitional movement. Okay, that'd be a great option. What else? Bilateral lower extremity. We can give it a try. Since, depending again, we have that dystonia, but so far it seems like maybe just the bilateral upper extremity is a little bit more effective. Okay. Tongue, I guess depending on the dysarthria, maybe that would be an option, maybe it wouldn't, especially if the dysarthria is progressive. Okay, so overall, I like the answers that we're thinking and the discussion that we're having. Okay, great job. Okay, so now let's go ahead and change this up a little bit. What if it was not dystonic cerebral palsy, but rather diplegic ataxic cerebral palsy? So we see that it's affecting her bilateral lower extremity. Her right upper extremity has range of motion within functional limits. Strength is 3 out of 5. Her right upper extremity, a contracture is beginning to form because that preferred position is a closed fist. We see slight tremors. So based solely on the information that was provided, what switch sites are we now considering? So again, talk amongst your groups. Okay, I'm hearing maybe the thumb still. Still think that's a great option, especially if that splint is there. Using facilitators like the splint, great job. Possibly a hand, forearm, okay. Great job. Okay, so now we're gonna go ahead and shift a little bit over to the stages of switch progression. So the stages are dependent on the literature that you are researching. There are switch frameworks that range between 4 steps to 8 steps. They are very similar, so we are going to be looking at the 4-step framework. Our 4-step framework includes exploratory, intentional, error-friendly learning, and independent. So here we have stage 1 and stage 2 of switch progression. So for stage 1, we have the exploratory phase, which we also want to call the cause and effect stage. This is when our patient will require max assistance to utilize the switch. And so we want to encourage activities that are preferred or highly motivating activities. And backwards chaining can be very useful during this stage. So let's go ahead and think back to that dinosaur example. So when that switch was activated, the dinosaur roared, it was lighting up, it was walking, and then when it was released, then everything went ahead and stopped. So this may be a highly motivating activity for a child. So for stage 2, we have intentional play. So now the patient may require mod assistance. We don't have as many choices available, but we do want to encourage the patient to intentionally select a choice. So this is to help them see a meaningful reason for activating the switch. So for example, the child would intentionally select a preferred activity, maybe providing two options, swing or music. We can then upgrade the play a little bit to activating an action figure or doll, but to be able to knock over some blocks. So again, it is much more intentional play, but we're still going to be able to require a little bit more of that assistance. Okay. So here we have that stage 3 and stage 4 of switch progression. So stage 3 will be that error-friendly learning or supported participation. This is when our patient will require min assistance. So mistakes here are encouraged, and this is when problem solving occurs. So we want to provide opportunities for greater practice for accuracy. This is when we can use programs that provide that feedback, such as creating their own songs or stories. And stage 4 will be independent. So this is when the patient can functionally use their device. So even though OT will be assisting speech therapy through this process, being aware of that switch progression is going to be the most important thing. And again, collaborating with your team, seeing how we can assist speech therapy through this process. In your groups, let's go ahead and run through this knowledge check. So let's recall the dinosaur video. In the video, the therapist was demonstrating if I push this button, the dinosaur turns on. If I let the button go, the dinosaur stops. What stage of switch progression are we at? Great, good job. Next one, child makes an intentional selection, more bubbles or gym time. What switch progression stage are we at? Good job. How much assistance is typically needed in error-friendly learning? Great job. And last knowledge check, let's identify the stages of switch progression in sequential order. Okay, we have 1, 2, 3, 4. Great job. These are the references in case anybody wants to look into a little bit more detail about anything we went over from today's class. Okay, does anybody have any questions? No? Okay, let's go ahead and separate from our groups and let's get ready for our quiz.